So thank you very much for the invitation to come here. At home it's so bad that it makes more sense of being on Skåne. And it's interesting that we can talk about such one topic the whole day. And as you know, when we talk about presbyopic treatment, we know what we talk about, but for the patient it's really difficult to understand. He wants to have the problem off, but to explain what we do, and we have to explain, it's really difficult. And I work now more than 20 years in presbyopia correction, and I think I have done many things on the cornea and on the lens, but I went back to the lens because it's the cause of presbyopia. And so let's see what we do. I like to talk about what you see. It's a lens, intraocular lens. It's called light adjustable lens, aspheric, 3-piece silicone, 6mm. So nothing really amazing. That what you can do with this lens is you can adjust after the surgery the sphericity and the toricity. It works perfect after corneal refractive surgery, and probably it will work perfectly after presbyopic treatment with a laser when it comes on. It has a 100% UV filter included, and the individual aberrations can be corrected in the near future. We talk about 55 eyes, and we have 55 eyes with 1 year follow-up, now meanwhile 3 years follow-up. I divide this in 34 virgin eyes. Virgin eyes means they have only cataract, and 20 complicated eyes, and these 20 complicated eyes are divided in 11 post-LASIK eyes. From these LASIK eyes, 8 had myopic treatment and 3 had hyperopic treatment, but all they had good vision. 2 eyes had a keratoconus, very interesting because they didn't know that they had keratoconus and we just detected it before the surgery. And we had 7 eyes with no reliable IOL master axis measurement. You know, that's posterior pole cataract where you don't get a real good measurement. 2 mature cataracts and posterior pole cataract. We did in 10 patients with 20 eyes, we did the Monovision treatment, and the intended refraction in the non-dominant eye was around -1 to -1.5. All these eyes which I just have shown. And what we try to do is we just calculate these lenses as you do normally calculate. So when we have a measurement around, so I want to meet ametropia with the dominant eye, also with the light adjustable lens, and I want to meet -1, -1.5 in the non-dominant eye. But it's a light adjustable, I can't adjust it afterwards. So in more than 80% we were ideal, in 15% we missed this aim. So sometimes we came in hyperopia or we had no monovision or something like that. What is nice and why I like to do that, because the patient is forced, in 85% in this group, to have monovision. So you have not to explain him what is monovision. You just do the monovision and then you leave him, because for 2 weeks the patient has, or for 4 weeks, the patient has to wear special glasses with 100% UV protection. And we tell them, and he has to accept that. And he wears monovision, and you must not explain it. And then you can ask him after 1 week when he comes back for after surgery control, how he likes it or he likes not. And so one patient understand it, and we had to change the dominant eye to the non-dominant eye, which is possible with the light adjustable lens. And what is also nice, all patients have post-treatment uncorrected distant visual acuity and good uncorrected near visual acuity depending on the light condition. And all 10 patients are not wearing glasses during daily work. 2 are using their glasses for driving, because in Germany you have to have glasses for driving. Even most of these patients don't take them. They just say they don't need them. This is the curve for the aim with the light adjustable lens in distance, and you see we are just always in between 1 diopter for the sphericity. And what is also very, very nice, and you know, Monovision really works only when you have no astigmatism, or the astigmatism is below 1 diopter. And this is the desperation of the patient with the astigmatism. They have 2 diopters, 1 diopters, 1.5 diopters. And the low diopters are always difficult to treat with toric lenses. And you see it afterwards, the toricity, the light adjustment is very strong in correcting also these small diopters from around 2 diopters round to 1 diopter or underneath 1 diopter. That is the line with the astigmatism correction. The stability is over more than now 3 years, very, very stable. So once the lens is locked, it stays there. You have 95% in between a half diopter, which is really nice to have them, especially after LASIK or you have a mature cataract. And so we have also side effects. One side effect is that in every patient they have erythropsia after every UV treatment, which is very, very strong, and I don't like it, and we have to work on that, is after the first lock-in treatment. After the first lock-in treatment, which is the most powerful treatment, they really have severe erythropsia for sometimes several days, but it disappears. And the variety of complaints of the patient goes from shrugging shoulders to severe blurred vision. 2 patients showed after the first lock-in a severe loss of visual acuity from 20/20 to 20/200, which is really severe. One patient, but only in one of the both treated eyes, the OCT showed a severe inflammation of the photoreceptor layers, so you could see immediately in the OCT. They all have a rehabilitation in visual acuity, but still these patients have deterioration in color vision. One patient, typical for a patient when you do something new, had fibrine in the anterior chamber. It's so rare that I see fibrine in the anterior chamber. I had a patient with light adjustable, she had fibrine. So the lock-in treatments were delayed, but it works perfect. And we had 2 patients with cystoid macular edema. One patient had it before the treatment, and one had it afterwards. So in summary, our first 12 months refractive results for the light adjustable lens show really reliability, stability, and efficacy. Especially in these difficult eyes, post-LASIK treatment, or where you have laser treatment on the cornea or other treatments on the cornea, show the same good results as with the eyes with only half cataracts. If you have an unreliable eye scan or IOL master measurement, it works really perfect. What I really like with this lens, that is the only lens I have in my whole selection of lenses. Up to now I have no positive and no negative dysphotopsia problems. And we have perfect correction in corneal cylindrical power, and the preoperative measurement from 0.5 to 2 diopters often is difficult, especially the IOL master is absolutely not reliable, so we always do a topography in these patients. And monovision is not easy to explain. Can we explain it? Or it's easy to explain and difficult to understand. And the intended post-op refraction is with a light adjustable lens, is monovision in these patients where I want to have that. And it works perfect. Every patient has accepted it. I had only one patient to turn the dominant eye to the non-dominant eye. The fine-tuning with this LDD, this is light delivery device on both in sphere and cylindra is very reliable, and the refractive outcome